morning, ladies and gentlemen. I must confess, after some panel discussions yesterday, I rewrote part of my talk, so I'm going to condense the title of this into 4 components and then talk about amputation prevention. We heard on the panels yesterday a lot about amputation, that we're getting better at amputation. Wells Care has spent almost a decade creating treatment algorithms, perfecting those to reduce unnecessary amputation, and it saves lives. So I want to talk through 4 concepts that are timeless, and then share some stats of this region and talk about how powerful that information is, and then go into some of the treatment algorithms, and then I'll leave some time for us to have conversation if you have any questions. So imagine health not as a solo battle, but as a symphony, where every instrument plays in harmony to create something greater than the sum. Today I'll share 4 timeless concepts from that symphony, condensed for our time today. Then I'll go into the stark realities this region faces, share some breakthroughs that my team has turned the tide on these chronic wounds leading to amputation. So the first concept is harmony of prevention, tuning our body before the storm. Picture a string section in a symphony. It's delicate, proactive, and it sets a foundation. Total health starts with prevention, not waiting for the crescendo of a crisis, but tuning our bodies, each a miraculous instrument, daily. In this region, where rapid change fuels risks like obesity and sedentary lives, we must harmonize nutrition, movement, and screening. Simple rhythms like a family walk under the Gulf sun, community apps tracking blood sugar can prevent 80% of complications of diabetes. This isn't theory, it's the first note played that keeps diabetes from deafening our lives. Concept 2, the rhythm of integrated care, syncing every beat. Now hear the percussion, steady, relentless, driving the pace. Integrated care is that rhythm. It's a regular cadence with endocrinology, podiatry, primary care, nutrition, vascular specialties, orthotists and psychologists in sync, not silo. In the Gulf's bustling clinics, we've seen siloed care lead to a 30% higher hospital readmission. But when we integrate, like a drumline marching as one, we catch foot ulcers early, stabilize hemoglobin A1C, and cut hospital stays by half. It's the beat that turns reactive into proactive, ensuring no patient falls out of step. Concept 3, the melody of community support, voices raising together. Enter the winds and brass, bold, uplifting, amplifying each other. Community is the melody that lifts us. Peer groups sharing stories over iftar, families learning wound care together. Isolation amplifies suffering, while connection heals it. Studies show supported patients adhere 40% better to regimens, reducing amputations by 1/3. In this shared cultural tapestry, from Rita Souks to Doha markets, this melody weaves resilience, turning me into we for lasting harmony. Concept 4 is a crescendo of innovation. Finally, the full orchestra can swell to crescendo, innovation as the grand finale. This looks like telehealth for remote Bedouin villages, AI predicting ulcers before they form, scalable programs like those preventing 1 in 5 high-risk cases. This isn't distant tech, it's accessible tools, and it's scaling across borders. The symphony peaks here, bold, adaptive, victorious. We conducted it before, now let's replay it louder. The symphony I just described isn't a dream, it's deployable today, but inspiration or conversation alone will fight this epidemic. We must face the score. The stats hitting the Gulf and MENA backyard are brutal, have devastating mortality rates. Let's look at some of those. Type 2 diabetes isn't creeping, it's galloping through this region. It's fueled by urbanization, wealth's double-edged sword, and genetics that we can't ignore. According to the IDF Diabetes Atlas in 2025, the MENA region bears the world's highest adult prevalence of diabetes, type 2 diabetes at 12.2%, affecting over 85 million people today. By 2045, that's an 86% surge to 163 million, doubling the cases in Gulf countries alone. We're not outliers here, we're ground zero. If you zoom in, Saudi Arabia leads with a 23.1% prevalence. It's 5.3 million adults living with diabetes 2, up from 20% just a decade ago. Qatar is 20.2%, with projections hitting 24% by 2025 as obesity climbs to 43% in women. UAE is at 20.7%, Bahrain and Kuwait pushing 21 to 22%. Six of the global top 10 are right here in the Gulf. Trends from 1920 to 2019, prevalence jumped 86% across MENA, with DALYs, which are years lost to disability, rising 31%. Without action, 500,000 more Gulf lives will be upended by 2030. And the heartbreak, these stats culminate in amputation, the silent thief of mobility, dignity, and even mortality. In Saudi Arabia, diabetes drives about 4,000 lower limb amputations annually, with major ones like below-knee amputations hitting about 1,647 a year. That's one below-knee amputation every 8 hours, roughly 1 per 500 diabetics. Scaled to MENA, 44,000 diabetes-related amputations yearly, 500,000 projected this decade. Below-knee amputations specifically, they're about 60% of the cases in Gulf studies. Minor at first glance, but gateways to major loss if unchecked. Qatar and UAE mirror this, rising 10 to 15% yearly in high-risk cohorts per the World Health Organization trends. Gets worse. Survival post-amputation is a steeper climb here than globally. In Saudi cohorts, all-cause mortality post-lower limb amputation reaches 86.8 per 1,000 person years, so over 8% annually, with a standardized mortality ratio of 7.2 times higher than non-diabetics. 30-day post-op death is 6.6% in RIDA's major cases, spiking to 34% with sepsis. 5-year outlook, 52 to 80% of patients that receive a below-knee amputation are no longer living. It echoes MENA's vascular burdens. So for context, even in the US, oftentimes set a gold standard, 50% one-year mortality rate post-major amputation, and a 29 to 69% mortality rate over 5 years for minor amputations. Another stat that we use in the United States is if you, after a below-knee amputation, two-thirds of those who survive lose their other leg, at which point you have a 95% 5-year mortality rate. It's huge. The bottom line is these complications are dismally higher due to delays in care. And they're not abstract. These are people losing legs at 45 years old, facing dialysis at 50, others who face dialysis at 50. The panels yesterday nailed it in talking about amputation. Amputation prevention should be the battle cry. So for the past nearly decade, my team at WellsCare, WELLS stands for Wound Excellence Limb Salvage. We've developed treatment algorithms that can prevent amputation in many cases. These treatment algorithms are solidly grounded in early aggressive intervention, multidisciplinary teamwork. This is primary care, wound doctors, wound surgeons, vascular surgeons, plastic surgeons. It's a group of specialists that all understand these mortality rates and that many amputations can be prevented. It saves limbs, and just like the stats we see, it saves lives. The stakeholders are also a huge part of this. These are people like home health agencies, hospitals, skilled nursing facilities, nursing homes. Anywhere a wound lives, this is problematic. Nobody across the United States has a solution. The problems are the same. The solutions are not readily available. And as we get outside of that, it seems to get less available, even in understanding. So aggressive early intervention is key. Patient accountability and participation is central to success. One of the most interesting things that I've seen is that most patients don't understand how sick they are when they have type 2 diabetes. They don't understand the disease process. Oftentimes, this is an educational thing, I see a socioeconomic component to that as well. but they don't understand how sick they are. They don't understand that type 2 diabetes, among other things, is a disease of their microvasculature. When the blood stops flowing and they bump their leg on the table and they develop a wound and it won't heal, it's ignored for so long, so many times. And there's not a lot of tissue between the outside world and their bone. Once it hits their bone, we have to amputate almost every time. And like these stats we just saw, amputation leads to a really high mortality rate. So while I can appreciate the advances that we make in our surgical approach to amputation, sometimes amputation is the answer. Sometimes that is the cure. But if we can prevent the amputation, and if we can get in and do early aggressive intervention, education of the patient, help them understand their disease process better, get their buy-in, get the buy-in of their families, teach their families wound care, get their families accountable for helping check sugars regularly. They're small things, but they take concerted effort. This is how we flip this epidemic, and we can lower the numbers. So even though those numbers the stats that I shared, they're kind of scary when you consider what that means. This region is primed for the change that we talked about at the beginning. We're excited to collaborate, innovate, and help bring prevention to this area. I'd love to hear some questions or thoughts on that. Thanks. Please.
Good morning.
Good morning.
I'm from India.
Good.
So most of the discussions yesterday and today I'm seeing related to psychology and a lot of other issues. Are we focusing on the nutritional food to fix these issues like type 2 diabetes, or most of the issues related to nutritional food availability? Do you think is enough that we created awareness among the urban generation?
To make sure I understand, you're asking me if nutrition is part of this? Absolutely. One of the things that we do with our patients is a mini nutrition assessment on the first visit. A lot of our patients are older, right? 50 plus years old. A lot of them, it goes back to this education thing. No one ever taught them how to take care of their bodies. I believe that to my core. It's we run a nutrition assessment. Depending on how they score, they get a nutrition consult. Oftentimes it's just pushing protein, right? They need to increase their protein intake. But nutrition is something that I feel like doesn't get talked about a lot. We're always talking about surgery and vascular and arteries, but the nutrition piece is equally as important. So we always take albumin, pre-albumin level. We run the mini nutrition assessment, make sure that they can actually heal, that they have healing potential. But this multidisciplinary approach that I talk about, nutritionists are very much part of that.
Do you think that in our education system, we are not induced so much emphasis on the nutritional aspects for the health and growth?
I 100% agree with that. I look at my stepdaughter's school lunch offerings, and it's fun, right? And I didn't have that at the school I went to, but it's not healthy. And I think every once in a while, that's okay. This is my first time to this area. It's awesome. The food is so different. It seems very healthy, right? I can't help but look at that versus how we eat in the United States. And I think we're way far away from healthy eating or even understanding that.
Thank you.
You bet. Thank you.
Thank you.
Good morning. Good morning, Brian.
Good morning.
I really appreciated your talk. I think you and your team have a lot to be proud of for everything you've accomplished. And my question to you is, what do you think is the most important aspect of prevention? You mentioned that was the way to go. What do you think is the most important aspect of that?
I think it's education. Like, it doesn't matter what we do, any procedure that we give to the patient. Sometimes I feel like we're pulling them along even, but the most important aspect is education up front, right? We have to get their buy-in. They have to take accountability for their disease. It's their body, it's their disease. We're here to help them. We can take them right up to the water, but the second you try to make them drink, you're gonna lose every time. We've seen it. We have tailored our program over the years to be, maybe it feels even, maybe a little cold even sometimes, but if they aren't participating, if they won't receive the education and they won't participate, there's not much we can do, you know? Any more questions? Yeah, please.
I just have a question, because as much as you're saying diabetes is a vascular disease, it's actually a disease that affects all the body. It literally shuts down your body one part at a time. So my curiosity is, when you're talking about education, what are the other elements of education? Who do we need to educate first to create a trickle-down effect instead of a going against the flow effect?
It's a great question. And to be clear, among other things, diabetes is a disease of the microvasculature, but you're so right, it's global, right? The impact is global for sure. When we educate the patient, whoever's surrounding them, like their close proximity, their inner circle, everybody has to be a part of that. We see this interesting window that happens with our patients. We'll show up and maybe half of them, we start telling them what to do. And I feel like they shut down really quick, right? Who are you to come into my house, or, you know, they're at the clinic or we're at the hospital. Who are you to tell me what to do? Unless they've had an event that has put them through the emergency room. Maybe they've received an amputation. Just kind of depends. It seems to open a window where more of them will accept what we have to teach them. But there's a lot of them that'll be resistant to it. So even though prevention is the goal, not everybody takes it, and not everyone takes the education. But to get back to your question, I think it's the patient and their close proximity, people in their close proximity. They have to understand the bigger picture so they can participate. Thank you. Yeah.
As somebody that was declared pre-diabetic and was able to go back to being on a normal sugar, I actually found, I'm blessed to have the NHS in the UK, and I was referred to what was called pre-diabetic sort of like coaching, where I actually found out that sleep is one of the major reasons why, lack of sleep is why you can get diabetes. What my question really is to you is, obviously the buy-in needs to come in from the patient, but how do you buy into kind of that education? And my question is, what are the spiritual approaches that you use at the Wells Care? Because I always feel soul-set solutions are not usually looked at in the healthcare industry.
First of all, congratulations. That's a huge thing to come out of it. It's a really good question, because I think we keep a separation. I mean, we're not spiritual workers, so it looks a little bit different. I think we show up with empathy, our team does, our providers are trained that way. I think we've all had an experience where it's clear that the doctor that's treating us isn't our friend, right? He's not interested in that. And so I think while we don't get involved with the spiritual aspect of it, because it's different for everybody, and I don't know how to do that, you know. I think we can show up with some humanity, compassion, empathy. That's how we train all of our providers. So they can show up, hear the patient, hear their concerns, and the patient can feel seen and heard, questions are answered. I think that starts to build positive attitude within the patient. And when they don't have that, they don't get better. I mean, I've never seen, trying to think, if I've ever seen a really ornery person just heal quickly. I don't think I've ever seen that.
I think me and you need to talk, because healing is within ourselves, and there are a lot of spiritual within ourselves. It probably would make the health profession go out of business, but let's talk.
Yeah, I'd love that. Thanks.
As as a functional nutritionist, we know that diabetes, especially type 2 diabetes, is mainly a lifestyle disease. It was supposed to appear after the age of 40, but unfortunately, I'm seeing children with 12 years old that they are getting diabetes type 2. And in your education, are you focusing, especially when the mother and the father, if it's a lifestyle, if they eat the sedentary lifestyle, the junk food they're eating, they're always on the screen, they're not moving. So they are developing this disease and the complication of this disease at a very early age. And I feel like we were able to reverse some of pre-diabetic patients or diabetes at early stages. We were able to reverse once we changed the lifestyle, like she said, the lady, sleeping, exercising, but also mainly is insulin resistance. We focused a lot on giving them tips and tricks on how to avoid insulin resistance, and food plays a major role in along with the sedentary lifestyle in preventing diabetes. I wanted to know what in your education program, what do you really focus and you're seeing it's working with diabetic patients?
From a nutrition standpoint?
Not necessarily. Do you focus on nutrition, or you focus also on lifestyle, on mind, body? What exactly works for you? So it's to inspire us also to add it to our system.
Yeah, that's a good question, and I think it varies patient by patient. Everybody is an individual with individual needs, and so it's not really a one-size-fits-all
Sure.
on what works, right? But our approach, it's nutrition, which is a consult with a nutritionist, depending on how their score is on their mini nutritional assessment on their first visit. The second thing, from an educational standpoint, is teaching the patients how impactful their disease is to their whole body. It's their mind, it's their organs. I mean, it ravages your body, right? Or it can if it's left unchecked, these high blood sugars. Helping them understand what's going on. And I think sometimes it scares them. Sometimes I wonder.
Maybe this will empower them to change, them to start applying what we teach them.
Right, totally. Yeah, and that's why we do it. We're not trying to scare the patients, but this is your reality, right? Do nothing, here's where you're going. Or if you can take control, take accountability of the disease, we can go a very different direction.
You know what, mainly what they do, they take the pill, and they think that by taking the pill, and I can eat whatever I want, and this is the main problem, that they continue with their life, just taking the pill, and they don't know how serious it is and the complications, as you said.
You're so right about that. Even these GLP-1 medications that are so powerful, and they can be they are so powerful, and they can be so effective if you make the lifestyle changes along with that, right? You have to do that part. So that would be the other thing we talk about, is what does lifestyle changes look like?
Thank you.
Yeah, thank you. Okay, thank you, everyone.